We're going to go ahead and get started. I'm going to use the mic here so that you can hear me, and also anybody watching can hear me as well. Because we are limited in time, and I know that people have schedules and will need to be on their way right at 2 or even a little or 3 and even a little before. We're just going to get started, and you're here on time. There may be a few trickling in, so just wanted to welcome you all. Thank you for coming. I will be handing around a form, and so if you would kindly sign it and pass it around so that everybody gets a chance to sign it. Put your email address on it so we can forward you the slides, and I would appreciate that. And so just going to welcome Dr. Benjamin Fortin-Langelier, something like that. Apologies. Langelier, who is with the Royal. He is he works. My understanding is he works with some of our students through the telehealth network, doing consultations, working with some of our health services people as well. He works at the Royal also in their ECT program, and also works in the north as well, going north on a regular basis. And we are really, really fortunate to have him with us, and looking forward to this. I think sleep is a hot topic, not just for students. So welcome, Dr. Fortin-Langelier.
Good. Thank you, Doug, and thanks everyone for taking the time to join us this afternoon. And thank you. I'm assuming thank you to everyone who came to Pembroke and people from Ottawa U and Carleton University as well. So I'm Benjamin Fortin-Langelier. I'm one of the psychiatrists at the Royal, and I do some of the clinics that we do with health services for Algonquin students. So it's a pleasure to be here again today. I was here in September for a talk on anxiety, and I'm coming back, I think, later in June for PTSD. So stay posted, and I think we have one of those once a month, and my colleagues are all fantastic, so come to those talks. We're happy to meet you. Today we'll talk about sleep. We'll talk about normal sleep. What is sleep? Why do we sleep? What's this about? We'll talk about developing a little bit of a clinical approach to insomnia. What do we do with sleep complaints? How do we make sense, triage people's sleep complaints? And then we'll talk briefly about pharmacological management of insomnia, so medication. And we'll spend most of our time discussing cognitive behavioral approaches to insomnia. The average adult sleeps 7.5 hours a night, and roughly 90% of the population is somewhere between 5.5 hours to 9.5 hours, and that's normal. So if you have no daytime fatigue and you're functioning okay and you sleep 6 hours at night, on an average basis, that's your normal. So anywhere between 5.5 and 9.5 might be normal. The average is 7.5. It's just important to have that anchor. So, for example, if someone wakes up at 8 in the morning and try to go to bed at 10, very likely that they won't be able to fall asleep at 10 if their average need for sleep is 8 hours. So just a nice number to keep in mind. We're not entirely sure of why we sleep, but all mammals sleep, so there is a physiological function. Sleep plays a role in memory consolidation, regulation of our temperature, regulation of neurons. We know that sleep is a different state than wake time, so we're not conscious, we're not aware, but our body is very much busy and doing activity that it doesn't do at either time. So we know that in terms of our EEG, brain waves, something different is happening. So in our wake state, there's desynchronized activity, so all different parts of our brain are busy doing different things. In sleep, interestingly, our brain waves tend to be more synchronized. What exactly does that do? We're not sure, but there is a pattern of activity that's different and specific to sleep, and if we don't have it, it tends to create some problem in dysfunction, right? So those processes are there, and they seem to matter, but even though we can't tell specifically down the line what does every little piece of physiological change during sleep does. There's also changes or things that happen in sleep at the neuroendocrine and immunological. So in terms of neuroendocrine immunological process, growth hormone secretion, transcription of DNA, neuronal activation, and so forth. This is hypnogram and EEG leads. So just to, sorry? No? Okay. So just to tell you a little bit about sleep. So what you're seeing on the right side is EEG, so brain waves measured with an electroencephalogram. So you see at the very bottom wake state. So you see smaller waves, higher frequency of peaks. You're seeing at the very top in REM, so rapid eye movement sleep, that's often called paradoxical sleep. So a pattern of brain waves that looks similar to the brain waves that happen in wake state. And you see stage 1 of sleep where there's some slowing of activity, and then deep sleep, used to be stage 3 and 4, now they just call it slow wave sleep. You see higher amplitude waves and just, maybe 3 to 4 peaks per second, so much slower frequency of activity. And you're seeing that the different stages of sleep in the hypnogram on the left are not distributed in the same way throughout the night. So the graph called the hypnogram, you can see that closer to midnight, so in the early phase of sleep, the sleeper goes from wake state to stage 1, stage 2, and then a period of deep sleep, goes back to, as a little bit of REM, back to stage 1 and 2, another period of deep sleep, and then at a later stage of the night, so more around 4 a.m., 5 a.m., there's no more deep sleep, but then there's a lot more REM sleep that's highlighted in red. So just to be aware of, so there seems to be something about sleep that early in our sleep, we have more deep sleep. That seems to be more important for physiological rest and restoration of the body. And then REM, that starts to be a bit more implicated in memory consolidation and more whatever psychological or emotional processing might happen in the night. That happens a little bit later in the night. And it's also one of the reasons why we might recall our dreams more, because dreaming happens just before awakening. There's some distinction to make between REM sleep pathology versus non-REM sleep pathology. So things like night terror are a phenomenon of non-REM sleep. Sleepwalking is a non-REM phenomenon. Nightmares or people with, say, Parkinson's disease that don't have the paralysis of REM may have REM behavior problems. So just those are terms you might have heard of, and I'm just linking them to normal sleep physiology. Another interesting thing to note, so in terms of activity in neurotransmitters, so all neurotransmitter systems, so acetylcholine, serotonin, norepinephrine, dopamine are very much active during wake state. And then there's more of a distinction of activity between non-REM and REM sleep. And so typically what that does is that in REM sleep, our brain is dreaming, so there's imagery, there's emotions, there's a lot of activity, but our body's paralyzed, so we're not supposed to enact our dream. That's what's highlighted in that diagram. So this is normal sleep. In terms of what drives sleep, so there's two main processes that drive sleep. One is called the homeostatic sleep drive, and that's the sleep depth. So the longer we're awake, the more we need to sleep. Very intuitive, not rocket science. The longer you've been up, the more you need to sleep. So that's the purple curve on the graph. So you can see that the sleep depth, so process S, increases as day goes on, and then comes back to a low point after a night of sleep. That's the shaded area. And then the other process that drives sleep is a circadian drive for arousal. So that's our the secretion of melatonin when darkness comes. That promotes sleep. The secretion of cortisol at around 7 to 8 a.m. There's a peak of stress hormone that tells the body to wake up in the morning. So we have a circadian clock. So our bodies has this 24-ish cycle where it tends to be a little bit more alert for, say, 12 to 16 hours and more prone to rest for about 8 hours. And that circadian clock adjusts itself based on environmental zeitgeist. So it turns around a 24-hour cycle, but it can recalibrate. So that's what we see with jet lag. When we move, we just recalibrate our clock and adjust to our environment. And then the sleep drive, so the sleep depth, is what's going to be most interesting, because this is something we can influence. We can't really tell the sun to rise earlier or rise later, but our sleep depth we have a lot more control over, and this is where behavioral interventions are going to be effective. Before we dig deeper, I just want to make a nuance between fatigue and somnolence. So I don't know if someone in the audience would want to take a guess or play a read my mind game and guess what I mean when I say what's the difference between fatigue and somnolence.
So fatigue is, if I'm correct,
Yeah.
is more like you're just naturally just tired, like your body wants to rest, versus somnolence is kind of that almost foggy feeling when you should have slept and you haven't
Yeah.
for days.
Yeah, so I'll repeat, and that's very much the nuance I'm trying to make, is that, fatigue is more a state of exhaustion. We've had a long day, we've been very, very busy, and we're more exhausted, versus somnolence is there's a need to sleep. We're more sleepy. It's hard to keep our eyes awake. So it's, because sometimes we say tired to mean both these things, but I'm just trying to nuance. So when we get fatigued or exhausted, what do we need to do? Good. So you guys are making the mistake I'm hoping you're going to make. So when there's fatigue, but some people that get it. So when there's fatigue, what we need to do is rest. So we want to change activity. We want to sit, talk, go for a walk. Just do something different. Take a pause, rest. We don't necessarily want that rest to be sleep. Because if we sleep, what happens to our sleep depth is we're sort of messing up a little bit with that process that makes us want to sleep at night, right? So if we're using sleep to fix fatigue, we can get into a little bit of trouble and start deregulating our sleep-wake cycle, and we're not sort of aligned with sleeping at night when we should. And what we do to fix somnolence is we go to sleep. So fatigue is what we, like after an intense activity that's been demanding, we feel fatigue, and then somnolence is if you need to stay up until 1, 2 a.m. Without caffeine and you feel sleepy. When I'll talk about insomnia today, I'll refer to insomnia disorder. So as per the DSM, so insomnia disorder would be dissatisfaction with sleep quantity or sleep quality. So difficulty initiating sleep, difficulty maintaining sleep, or early morning awakening with inability to return to sleep. So any type of dissatisfaction with sleep that causes significant distress or impairment. That happens at least 3 nights a week for at least 3 months, despite adequate opportunity for sleep, right? If someone just had a child and is nursing or breastfeeding, they don't have insomnia disorder. They lack adequate opportunity for sleep. Insomnia disorder becomes a little bit of an exclusionary diagnosis, and that we want to make sure that this sleep impairment is not caused by another sleep-wake disorder, things like narcolepsy, breathing-related sleep disorder like obstructive sleep apnea, circadian rhythm sleep-wake disorder, or parasomnia. Sorry, and the screen went, it's back, okay. And it's not related to substance use, and if there's a coexisting mental health disorder that causes sleep impairment, the sleep disturbances is significant enough that we want to list this as a comorbidity to address it on its own. In terms of insomnia, so a lot of people have sleep complaints, so some degree of dissatisfaction with sleep, 30% of the general population, up to 1 in 10, up to 10% of people will meet criteria for an insomnia disorder based on the criteria of the slide before. Acute insomnia is usually related to transient phenomena, so injury, pain, stressful life event, environmental factors. We're not talking about insomnia disorder. If there's construction work happening and we can't sleep, so acute insomnia is usually a transient phenomenon. But then it can become chronic, and this is where we would call it insomnia disorder. In terms of an approach to insomnia, we're going to look at if it's an acute insomnia, what's the triggering factor? Is there a stressor? Is it in the environment, injury, these type of things? We want to normalize that it's normal that sleep will be somewhat impaired at time of high stress. How can we problem solve? Is there anything we can do to reduce the impact of that stressor, to change a little bit the environment, and address any predisposing factors? So say there's a new stress that's triggering insomnia, but that person has a long-time habit of looking at their screen just before bed, or smoking cigarettes just before bed, drinking coffee around supper, so addressing predisposing factors. If it's in the context of another psychiatric condition, so we might want to just screen, is this part of a generalized anxiety disorder, major depressive disorder, PTSD, so all types of psychiatric illnesses where sleep impairment is just part of the illness, is usually actually one of the defining criteria. Rule out another sleep disorder, and if that's not the case, so if it's no longer acute, if it's not just part of another psychiatric condition and not part of another sleep disorder, then we're thinking about chronic insomnia, and the CBT for insomnia strategies we'll discuss today are probably applicable. So just to make sure that we don't, throw these strategies at everyone, because not every sleep complaint would be part of chronic insomnia and wouldn't necessarily respond to CBT for insomnia. I've got 1 or 2 slides on meds, so just to let you know, because you will see patients or students taking those medications, so just so you know a little bit what they are. So in terms of medication options for insomnia, there's certain antidepressants tend to be a little bit more sedative, so I'm sure you'll have seen things like trazodone, mirtazapine, or older antidepressant, tricyclic antidepressants, doxepin, amitriptyline. So those are sometimes used for sleep. It's off-label, but they do tend to work, so you'll see them. The Z drugs, so benzodiazepine receptor agonists, things like zopiclone, zolpidem, so you'll see those too. And those are actually approved for short-term management of insomnia by Health Canada. Benzodiazepine also approved, but a little bit more problem with addiction, risk of misuse, physiological dependence. And we sometimes use off-label atypical antipsychotics, things like quetiapine, olanzapine, and over-the-counter. So if you buy Sleepy's or any type of over-the-counter hypnotic, those are usually antihistaminics. So essentially Gravol or Benadryl equivalent, just given a nice fancy name, and it's all marketing, but antihistaminics. Dose options tend to be somewhat effective, so this is essentially numbers and table that tells you that they work. But what's interesting about that table is I just wanted to discuss some of the outcome measures. So when we do a trial, when we look at designing an intervention that can promote sleep, what are the things we're going to measure to see if our intervention is working? So some of those variables are on the right in the table. So SOL stands for sleep onset latency. So one of the variable is what's the time difference between the time our head hits the pillow and the time we fall asleep. So if I go to bed at 10, fall asleep at 10:30, my sleep onset latency is 30 minutes. And if I've got a sleep onset latency of 15 minutes, I might be somewhat unhappy with my sleep and would want to do something about it. And if it goes from 15 minutes to 20 minutes, I'll be happier. So it's just specific vocabulary, or just introducing a couple of nuances in terms of how we talk about sleep and sleep quality, and what's disrupted sleep and what might be improved quality sleep. The WASO, so the wake after sleep onset, would be what's the amount of time that we spent awake after we had fallen asleep in the first place. TST stands for total sleep time. So it's the total time we spent sleeping in the night. And so those 3 ones everyone is much aware of that. Like this is how we talk about our sleep efficiency. So the last one is something that's more, like I really want to make sure that professionals are aware of. So sleep efficiency is actually one of the bigger outcomes in the trials. It's the time asleep divided by the average time spent in bed. So it's a percentage. So of the 9 hours you spent in bed, were you sleeping for 8 hours or for 4 hours? And that's usually what we'll want to try to change with an intervention, is make sure that sleep is efficient. So we're not necessarily going to target how long you sleep, but we'll want to make sure that you sleep when you should. So sleep efficiency. And so the effect size, if you're saying something that's around a 0.5 is a medium effect size, it's a good outcome. So most medication, benzodiazepine, the Z drugs, sedative antidepressants, will have a positive effect on all those variables and will reduce sleep onset latency and wake time after sleep onset. And so the drugs are effective, but the problem is that usually those are short-term studies, so roughly about 4 weeks, so it works in the short term, but what do you do after you stop the drug? This is where people get into problem. And then what's the risk of giving someone a benzodiazepine at a very young age where they might become dependent and might create more problem than it solves. Cognitive behavioral therapy, so measured against the same outcome, would have similar efficacy. So just, I mean, you don't need to retain those numbers, but just so you're aware, we're talking about an intervention that's been studied and proven and works well, and you can go back to those slides for the references and the full details. So I'll talk now about the cognitive behavioral therapy protocols for insomnia. And so the first part in every therapy model, every therapy model as a way to formulate a problem based on, based a little bit on their own paradigm. So every school of thought has a way to define an issue. So let's try to define insomnia as a cognitive behavioral problem. And one of the ways to do that is so using this graph, we're looking at, most people who present with insomnia will have some degree of predisposing factors. So it can be alcohol use, tobacco use, tendency to take certain naps, screen time. So no one's sleep hygiene is 100% perfect, but it doesn't mean that we suffer from insomnia. But once we start suffering from insomnia, we might want to become a little bit more aware. So people have predisposing factors. There's usually something that can make us acutely insomniac. So I had an exam, a child was born, I had an episode of depression, they were doing constructions, the hair was different, the temperature was different. So for whatever reason, I started having a problem with insomnia for a limited period of time, but sometimes that acute insomnia becomes chronic, partly because of what happens during the acute episode of insomnia. So I'll illustrate that using the CBT approach. So you might have a situation where someone has an acute period of insomnia, and then they develop certain thoughts about what happened. So, oh my God, I only slept 4 hours last night. I'm not going to be able to function at work tomorrow. My performance is going to be terrible. I won't be able to do everything I need to do. And so people start worrying about the fact that they didn't get enough sleep. And we might try to compensate for that lack of sleep. I'll make sure I drink 2 Red Bulls this morning. I'll make sure I nap. I'll make sure I do something to compensate. But then what that might do is foster, so what the thoughts and the compensatory behavior might do is increase our arousal at nighttime. So now I've been drinking coffee all day, or I've been worried about not sleeping all day, and comes night and I'm not able to sleep still. And then I'm going to get distressed about this, and it just reinforces the whole cycle. So the idea is that these things are going to the perpetuating factors of chronic insomnia are not really related to what caused it in the first place. And so we may not be able in therapy to fix this, but we're probably going to be able to fix this. Here. Good. And the most powerful drive we're going to use is focus on behaviors. That makes sense so far? Good. so behavioral model, like those are theories that are very, very simple, but at the same time very elegant. And I think one of the challenge is mapping a problem using those principles, right? And using them well in therapy is what's challenging, because the theory is just very, very, very simple, right? We have learning by association. Food triggers salivation in a dog. A whistle triggers nothing in a dog, or maybe it's a little bit unpleasant for the dog, but certainly wouldn't trigger salivation if presented alone. You start pairing the stimulus, and all of a sudden, the dog is conditioned to salivate when exposed to a whistle. And what we're going to want to do, or the association or the learning that we'll want to emphasize in CBT for insomnia, is that bed equals sleep. When it's nighttime, if you go in your room, if you spend time in your bed, your body knows that now's the time to sleep. And this conditioning is very powerful. It's a little bit, so just before I was giving that talk, I wondered, you know how in grocery stores, most doors are automatic doors, right? That if you try to push it and open it, it just slows it down. So I've been conditioned that when I leave the supermarket, I stand and I wait and I sleep before the door. And then, of course, I change supermarket and it doesn't have an automatic door, and I just stand there like an idiot. Because I've been conditioned, you know. So there's a nice dog that just wants the treat inside of all of us, and we just respond to stimulus and cues, and we get conditioned. So let's use this in the favor of the people we're trying to help. Two main paradigms of behavioral treatment for insomnia. The first one is stimulus-controlled therapy. The second one is sleep restriction. Stimulus control includes the basic sleep hygiene, so no caffeine after 12 p.m., limit to 1 to 3 coffee, tea, or soft drink. There is a little bit of caffeine in decaf, like much less, but anywhere between 10 to 25% of the quantity of caffeinated coffee in decaf coffee, so just being mindful of this. We probably want our bedroom to be a little bit too cool than too warm. No naps during the day, limit the use of alcohol. So alcohol is a central nervous system depressant, right? So when our brain is exposed to a depressant, it compensates by activating. When you remove the depressant, you just have an overactive brain. So alcohol really messes up sleep architecture. Limits cigarettes before bedtime, so it's activating, it binds to a nicotinic receptor, and it promotes arousal and awakening. Regular exercise, just to make the body tired. The room should be dark and quiet. So basic stuff. And then the other part of stimulus control is, again, we want that pairing of bed is for sleep. So the bed is for sleep and sex. Nothing else. It's not for reading, it's not for resting when you're fatigued, it's not to watch TV, it's not to play Candy Crush on your phone. It's and you know, and if it helps, just put the phone charger somewhere in a different room. And so we need to, again, we're just trying to train the mammal part of our brain. Like it's just training. So we need to associate the bed with sleep. And if I'm in bed and I'm not asleep for more than 25 minutes, I'm starting to, you know, I'm cueing my brain that, oh, bed is for thinking about all the things I should have said during the day and I didn't say. My bed is for, you know, bed is for revisiting imaginary, winning imaginary arguments with people. Like this is what the shower is for, not the bed. So if I'm in bed, I'm awake, it's been 20 minutes, change room, go do something quiet, and then come back. So that's stimulus control. So simple, again, but can be somewhat challenging, and we forget these things. So sometimes we tell ourselves stories of why those advice don't apply to us, or we can't implement them. Well, if I don't drink, I'm way too anxious and wired, I won't sleep. If I don't use cannabis, I won't sleep. If I don't, so I think we just need to be mindful that we know these things, but we're really good at finding excuses not to do And yeah, please.
Am I allowed to ask, or?
Absolutely, yes.
It just had to do with the stimulus control.
Yeah.
Oftentimes we hear too, trying not to sleep in a cluttered room. I don't know if that's something that you would put on that list of stimulus control, like when the room is so cluttered that you can just stare at those things.
Right.
Imposing it on you, would that be one of the things that you would recommend not to have in a room?
Yeah, I think it goes along the lines of, we're trying to create a space that's amenable to rest and restoration. So, yes, and this is, when people give the advice of writing down all your worries before going to bed so that your head is empty before you go to bed. So, making sure that, yes, your room is an environment that feels comfortable, because chances are if there's clutter, you kind of need your brain to be active to ignore it. Right, so ignoring is an active cognitive process, so it becomes a little bit taxing to not worry about the clutter. So if there's, again, the less we have to worry about, the easier it's going to be to fall asleep. Yes?
So you have to get up after 20 minutes. So what's the normal or healthy amount of time that it should take you to fall asleep?
An average sleep onset latency would be roughly 20 minutes. Well, yeah. I mean, it's funny. So, yeah, it's roughly 20 minutes, and the interesting thing is sometimes, when we're anxious, I think we have the perception that we're sleeping a lot less than we actually are. So I think most of the time, I mean, and 20 minutes might be an average. So within a half an hour is normal. Like I won't worry. I usually will avoid prescribing a medication if someone has a sleep onset of 30 minutes. I'm not going to worry about it. Like if it's 50 minutes, I can see how it becomes problematic. But average would be 20. Yeah.
Is it true that if people, the instant they put their head on the pillow, they fall asleep because their body is so exhausted? And if they have that every night, that they just fall asleep like this, it's not good?
I mean, there is something to be said, right? So we were talking a little bit about the sleep efficiency. So if, say, someone's sleep efficiency is 95%, because they spend 7 hours in bed and they sleep 6 hours 45 minutes, maybe they're a little bit sleep deprived. So I think that's how I would interpret it, is maybe they're not giving themselves enough time to rest. So it's not so much that falling asleep quickly is the problem, but it's just if they're chronically fatigued or not resting enough, then that might be a side effect of that yes, their body is just so tired that they do need to sleep. So that's what I would look for. I'd say, are they giving themselves enough time to rest? Yeah. So yes, it can be a symptom of that. Any other thoughts on sleep and stimulus control? Yeah?
Just on that, I mean, there is a certain amount of conditioning that can be done. I've managed to do that so that by the time there's certain activities such as wearable bed covers, by the time you get into bed, and then using the bed just for that,
Yeah.
like changing that whole routine, and yeah, sure, you put your head down there, it's like, thanks, see you later.
Right. So we're talking about like activities that can cue the brain to sleep. For example, if yeah, totally. No, but it is. So any type of routine that cues us that this is what's about to come. Yeah. Like if the only time I do Sudoku is 15 minutes before falling asleep, then like that becomes a cue, and yeah, that's valuable. Yeah. So I'll get into sleep restriction. So in sleep restriction, our goal is really to increase sleep efficiency. So what we want to do is make sure that when people are in bed, they're sleeping. We're not necessarily going to worry right away about making sure that people sleep more, because that can be a tough target. So so people will come with the complaint that they're not sleeping enough, and then we need to introduce the nuance that they're not sleeping well enough, and then once they sleep well, then they can sleep longer, if that makes sense. So the goal is to increase sleep efficiency, time of sleep divided by time in bed. That's a marker of quality of sleep. What we're going to be doing is, in terms of task of therapy, we're going to use the sleep debt, so the process S, to normalize sleep pattern, and we're going to use sleep diary to monitor what's happening and set up a treatment plan. So if you're thinking of principles of therapy and developing a strong therapeutic alliance with someone, you know that we need agreement on goals, agreement on tasks, and then a good bond, a certain liking of one another. But then our job is to make sure that the person we're working with buys into that goal and task. So I just want to make sure this is pretty explicit. So what we might want to do is use sleep diary. So this is one example. It's going to be in the slides that you'll get. There's other examples. The idea is to track a little bit the activity people have during daytime, how many naps, how long in total have they been napping, use of cigarette, cannabis, alcohol, exercising, what meds they're taking, any significant stressful events. And then we want to make sure people track their night. What time did they go to bed, what time they fell asleep, what time they woke up in the morning, and what time they were out of bed, right? Because sometimes we're up at 6, thinking about how our sleep was terrible, then our day's going to be awful because we didn't sleep, and trying to sleep again, and then really we're spending an hour and a half in bed even though we're not sleeping. So just time wake up, time out of bed. How many times in the night did we wake up? And how much time total during the night were we awake, we think? And then we'll want to calculate the sleep efficiency. So what was our total time in bed divided by, what was our total time sleeping divided by our time in bed? And that becomes our sleep efficiency, and we can average these numbers every week. So it's sleep diary, and we'll want to have a couple of those, and then we can start making a prescription to shift certain behavior in order to increase the sleep efficiency. So what we're going to do now is we can do a race between the left side of the room and the right side of the room. I want to know which side of the room can calculate the sleep efficiency the fastest. So this is the example of a sleep diary. The person went to bed at 10:15, fell asleep at 11:15, woke up at 6, was out of bed at 7, and woke up twice for 30 minutes during the night for a total spent awake in the night of 60 minutes. So this is your total time spent sleeping, 5 hours, 45 minutes, and total time in bed, 8 hours, 45 minutes. And in the Pembroke and Carleton and Ottawa U, I won't be able to know your answers, but please try to do the maths, because that metric is key for designing a treatment schedule. So sleep efficiency. I wish I had Jeopardy music.
Do you want the number?
Yes. 65%. And how did you get to 65%? Yes, so it's just easier to do it in minutes. So you've got 345 minutes divided by 525 minutes, and that is 65%. Yes. Now, just intuitively, does 65% sleep efficiency, does that sound reasonable? If that person spent an 8-hour, 45 minutes in their bed and only slept for 5 hours, 45, do you think they're going to be happy with their night? Probably not. It's not great. So in terms of those metrics, so if what's easy to change? So it's kind of hard to focus. I can't really focus on the time I spent, the amount of time I woke up during my night. If someone has a habit of waking up and going out for a smoke, like that's a behavior that we can change, but it's going to be hard to change that metric. So line 18, not much we can do about. Time out of bed versus the time, so time out of bed is something that we can behaviorally choose. The time we wake up, not really. And then the time in bed. So those are the two main ones that we can actually control. So if I want to increase my sleep efficiency, what should I do with my time out of bed? Get up earlier. So once I'm awake, I should get out of bed, right? Because if I woke up at 6 and I'm out of bed at 6, then all of a sudden this fraction becomes 5:45 divided by 7:45. Sleep efficiency is going to be higher. And and then in terms of time in bed, like what should I do with my time in bed to increase my sleep efficiency? Should I go to bed earlier or later? Later, yes. And this is where it becomes a little bit counterintuitive, right? That we call it, thank God they call it sleep restriction therapy, but just to have sleep restriction therapy prescribed for insomnia is a little bit counterintuitive. So that's what I really want to illustrate and make sure that people take this away today, that we focus on sleep efficiency, and if we spend less time in bed, our sleep is going to be more effective. So the ideal sleep efficiency is roughly 85%, because if it's too high, maybe someone's a little bit sleep deprived and doesn't have enough time to rest. So if I want to get it closer to 85, what I would probably want to tell this person is listen, you've been sleeping, say this is not just one night, but this is the average of 2 weeks. So you've been sleeping roughly 5.5 to 6 hours at night. So what I'm going to do is make sure that you don't spend more than 6 hours in your bed. So that might be a little bit of a tough sell, but this is not something we do, week one when we meet with the person, because we have them track their sleep for 1 to 2 weeks. But then, listen, this is what's already happening. And you're kind of functioning on 6 hours of sleep. You've been going to class, you're a little bit more tired. I'm not saying you're functioning at your best capacity, but you didn't die. So let's try this together, where we'll set your alarm at 6, and your job is to get out of bed right when your alarm rings, and whatever strategy you need to do, put your alarm clock farther from your bed, or any type of strategy, let's just try to do it. And then you're not allowed to, you shouldn't go to bed before midnight. And it's not a major restriction, because I'm already giving you what you're getting. Yes?
You were saying that you have, speaking of alarm clocks, and also that you have no real control on when you wake up, so which is why people use alarm clocks. For those of us, I'm a firm believer that in behavior therapy,
Yeah.
that you can control exactly when you wake up. And it doesn't matter what time you go to bed. I do it on a regular basis. I need to do this. And it seems like it's it's something that you train yourself to be able to control. I don't think
Yeah.
it's up.
Yeah, no, so we can train ourselves a little bit to wake up at a certain time. I think what I mean by, if someone has insomnia and they tend to wake up spontaneously at 4 a.m., and that's something that's not necessarily something they feel they can control. But if we're saying, we're putting your alarm at 6, and you need to get out of bed when your alarm rings, like that's something you've got lots of control on. So I think you can suggest yourself and train yourself to wake up at a certain time, but it's a bit more that sort of subtle training. And it's almost part of what I'm suggesting you're going to retrain yourself to sleep when it's time to sleep and be up when it's time to be up. So similar principles, but I'm really trying to make sure that people have full control on those two variables. You fully control, once you're up, do you leave your bed? 100% under your control. And what time do you go to bed at night? 100% under your control. But I see where you're going, and this is similar to what we're doing here. Yeah. Yeah.
I'm wondering, I'm assuming the approach is still the same for those, though, that there's a lot of variables that they can't control. For instance, when they're going through hormonal shifts, like perimenopause, menopause, or if they have a health condition that might create night sweats or things that make them actually just waking up in the middle of the night. Is it still the same application, or would you shift anything?
So I think what I might want to do, so I'll get to that in the next slide. Yeah. I'm mindful we've got about 15 minutes left. I'll try to finish the slide decks in 5 minutes, and then make sure we've got a good 10 minutes for discussion. So in terms of prescribing sleep restriction, the first thing we want to choose is a wake-up time. And that's going to stay the same throughout treatment. And then what we'll want to do is delay the time to bed. And as people's sleep efficiency increase, then we can go to bed a little bit earlier in the night. So once the sleep efficiency gets corrected, then we get more sleep. So we're using the sleep debt, we're using sleep restriction to make sure that we're conditioned to sleep when we're in bed. And once that's done, then we can focus on sleeping for a little bit longer and making sure that people are not chronically sleep deprived. People are coming to therapy already somewhat sleep deprived, so they're going to do something that's going to be challenging for 2 to 3 weeks, but it does get better. Yeah.
Now, can you use these applications for people who work shift work?
So yeah, shift work will be a lot more challenging, right? Because you can't. So that's why. So shift work would be part of sleep wake cycle disorder. I can't remember the right name, but yes, sleep. That's why shift work creates sleep problems, essentially, because you can't get into a rhythm that's sustainable.
Especially if you're casual and you
Yeah.
don't know, you can't make.
Yeah. So that's a whole different talk. Yes.
You'll do that later.
I'll do that later. Yeah, so that's where we prescribe the sleep restriction. So in a nutshell, so what we want to do in treatment and what you'll see if you use any type of manual for CBT for insomnia is initially we want to focus on helping people understand sleep, its function. We'll make sure that we've got an agreement that we're going to work together for the next couple of weeks on specifically insomnia. Someone may have other problems in their life. It's okay. But we've decided that maybe they're going to be a bit more rested, or a little bit more in a better place to face those problems if their sleep is better. And we're really going to focus the 45, 50 minutes we've got together for the next 3 months on improving their sleep. So making that the focus of therapy, getting people to implement sleep hygiene strategies, so starting the stimulus control piece. And while they do that, they start tracking their sleep using the sleep diary. And then when we're ready to prescribe sleep restriction, we choose an anchor wake-up time. And then we'll choose the time to bed usually based on how much the average sleep they're already getting, as long as it's a little bit above 5 hours. So if someone has a wake-up time of 6 and tends to sleep for 4.5 hours, we might say, you're going to wake up at 6, and you're not allowed to go to bed until 1 in the morning. If that's not enough, then we might push it to 1:30, but rarely do people need to go for much less than 5 hours. Yeah. And then the time to bed can be advanced slowly as long as sleep efficiency is preserved until daytime somnolence is resolved. Quickly, there may be some maladaptive thinking that people have about going to bed, about laying in bed, about sleeping less than 6 hours. So there's once the behavioral process has been well set up, and people come to session, session more, say 6 session. Say if you've got a 8-session protocol, session 6, 7 is probably where we do the cognitive work. So people may have catastrophizing thoughts about sleep. If I don't sleep 8 hours, I won't be able to function. If I can't sleep, I'll go crazy. They might be already thinking from the morning, I'll go to bed and I won't be able to sleep. I never sleep well. I need to nap, otherwise I don't function. So all these thoughts can be addressed in a classical cognitive therapy paradigm. A couple of self-help resources. Good English book, Overcoming Insomnia by Jack Ettinger, and there's a Montreal sleep researcher, Charles Morin. So there's a great textbook it's the original is in French, so it's not a translation, Vaincre les ennemis du sommeil. And I'll show you a website that I like. Hopefully it works. Yes, good. So mysleepwell.ca is from the University of Dalhousie in Halifax, and they have great tools for CBTI. They have an example of sleep diary if you like it, They have a sleep calculator to calculate the sleep efficiency. And so you get a sense, like this is like a standard protocol that has slightly different variations, but essentially people are talking the same language, whether it's in the Maritimes or here in the province of Quebec or in the UK, the US. So very well-validated protocol. Simple theory, a little bit of a tough sell, and challenging to stay accountable and be consistent with those metrics. But it works well, and it's just there's also a couple of quick intuitive things that are useful to have in mind whenever we're having a conversation about sleep. So I always sort of have those principles, whether someone comes for mainly anxiety or depression. So those are nice tools and nice little tidbits of knowledge. So thanks a lot for being here. We have lots of time for, 5-7 minutes for questions. But thank you. If anyone needs to leave, please go ahead. And then at 3, I'll just shift over from the camera, but I'm not in a rush. I can stay and talk. Yeah.
To go back to that, would you shift the protocol for people to wake up physiologically, something that is going on? Is the protocol different?
So when we assess the insomnia, if the main problem is, say, hot flashes in menopause, then I wouldn't necessarily frame this as insomnia disorder. I would say if someone has developed chronic insomnia during their perimenopausal period and they no longer have symptoms but have continued to have impaired sleep, this is where this therapy is going to work really well, right? So the precipitating factor is no longer there, no longer acute, but we've got into a pattern of thinking or behaving that has maintained chronic insomnia, and this is where this therapy will work. Otherwise, I would want to just try to problem solve around the acute trigger for the insomnia to see if there's anything we can do for those symptoms. So I would, here, so I'd frame that more as acute insomnia and try to address the precipitant. Yeah?
What's the efficacy of melatonin supplements and other long-term concerns or concerns about being on it long-term?
So to my knowledge, there's no major risk of melatonin. It doesn't necessarily interfere with endogenous production of melatonin. In terms of its efficacy, so it's more effective. Melatonin is part of process C. So melatonin is more effective to help sort of shift the circadian cycle. It's not a big sleep promoter. It's mildly sedative, so it would. I don't have it in that table. Like I don't think we have the same data and meta-analysis. I can't tell you specifically how much smaller of an effect size. I think it's safe. I think it's slightly sedative. It's better. Its best use is to shift this. You can see my cursor. So it's more to shift this for jet lag, for example, and melatonin would be best used 2 hours before going to bed. Like it's not something that it's not an hypnotic. It doesn't induce sleep, really. But can somewhat promote sleep. Yeah.
Can you tell us a bit more about medications that can negatively impact sleep? That students may take for things like depression, anxiety, or ADHD?
Sure. So the question was, what about medications that can negatively impact sleep? So so any psychostimulant, so all the ADHD medication or psychostimulants can have, as a side effect to promote arousal or awake state when it's time to go to bed. So we want to make sure that, so if there's a certain dose where it creates insomnia, but maybe the dose before it didn't, want to make sure that people take them as soon as they wake up, 6, 7, 8. So all psychostimulants can do that. In terms of antidepressants, bupropion is probably the bigger activating one. So usually we would prescribe it because someone is asking for something activating, but it can have the side effect to interfere with sleep. Most antidepressants, it's hit or miss. Like some are a little bit more sedating, and it's better when taken at bedtime. For some people, it might be a little bit activating, and it's better if they take it in the day. But so it's rare that we can't do something to work around that side effect. So like those are not medication that will necessarily negatively impact sleep architecture or create problem long term. I think when people are recovering from alcohol use disorder or stimulant use disorder, then we can see that it might take a good 6 months to restore a normal sleep architecture, because like the dose of neurotransmitters in with cocaine, with speed, is much higher, and then the effect of alcohol is different. It's not on norepinephrine and dopamine, but similar. So the chronic use of alcohol or stimulant can interfere with sleep architecture. Not necessarily something we would see at the doses where psychostimulants are used for ADHD. It's more, a dose issue or timing issue that we can address. So sometimes those patients do respond a little bit better to melatonin. Yeah. Thank you. Yes? Yeah.
I think one of the challenges is that whole kind of 30-minute, laying in bed, if you haven't fallen asleep, to get up and do something that's resting, but it's like get out of bed. And I think a lot of people, when I talk to them about that, there is that kind of thought that if I get out of bed, then I'm going to wake myself up more, right? So it's better for me to be lying there.
Mm-hmm.
And I'm just wondering with acute issues, is it oftentimes like are you trying between the getting out of bed, being restful, and then kind of moving on to a restrictive sleeping, where you're actually just making the bedtime later, or like how do you, I guess, in acute issues, what is usually the
Right. So, I mean, in terms of acute problems for sleep, so we're thinking about something that has lasted for less than 3 months. And usually we can try to identify a precipitating factor. And that's what we'll want to work around. Like once it's chronic and there's no clear precipitating factor, then it makes sense to implement stimulus control and to say, well, you've been laying in bed for 35 minutes with your thoughts, and we're sending the wrong message to your body that laying in bed is for thinking about planning your next day. So get out of bed, sit on the sofa or change room, put dim lighting, and read or do a crossword. Don't use a screen. Don't do something that's going to be stimulating, but go change space. And when you're sleepy, then you can go to bed. Like there's no point in staying in bed. Like you're already not sleeping. And it also helps people distinguish between fatigue and somnolence, and it might make that cue as like, okay, I was out of bed, now it's been 3+ hours. I'm really sleepy. Like I can't keep my eyes open, so now's the time for me to go to bed. So it's not a bad thing, because we're looking at because those are interventions that people do to normalize their sleep. It's not necessarily something they're going to do for the rest of their life, right? So we're trying to correct a bad habit or trying to shift a pattern that's become problematic, right? So if it's acute, less than 3 months, and it's not creating much suffering, there's no point really in doing that. Like it's not necessarily indicated, but if it's been more than 3 to 6 months, someone's already not sleeping, and so we're undoing a maladaptive pattern. Yeah.
What extent do you use the medication and the CBT concurrently, or are they separate?
They can absolutely be concurrent. Oftentimes, the CBT, so implementing CBT is a good way to help people reducing their dose of medication, especially, if it's someone's main antidepressant that's somewhat sedative and they're supposed to stay on it, we won't want to change it, but it's something that we specifically prescribe to address the sleep problem that we thought was going to be acute but has become chronic, then we might want to use a CBT for insomnia to normalize the pattern and take advantage of this to slowly taper medication if we don't think it's indicated in the long term. Yeah. So so they can be combined as sometimes, well, we might want to use CBT to reduce meds. Yeah, and this is where the tracking in sleep diary, and so paying a lot of attention to that will be helpful. And sometimes, if people are asking for therapy, it's usually a sign that medication alone has not been quite effective. Yeah, it's 3 p.m., so I just want to be mindful if I'm sure people have commitments, so feel free to come in and chat, but I want to make sure you can all go. So thanks a lot for coming again. That sums up a lot of advice.
there's always the larger network that has its advantage. But there is also that advantage of kind of working with
Yeah,
your peers or
it's
people
fine
who are doing
until they
similar
start
work to
coming.
you.
They're a smaller group, they create.
Well, that's it, that's it, exactly.
Because they're
That's
more
it.
challenging.
It doesn't have to be a large number to kind of go, what do we do?
And that's what like.
You know, with the psychosis, you know, somebody sitting in the room with you.
Yeah, so that you, I mean, there's advantages to
told
both,
Sarah
but I do see.
Oh, you did?
I changed my mind, so.
That's good to know.
Thank you so much, Doug.
Oh, yeah. They're always a big asset.
Thank you.
Because they are, I invite them, I always invite them, I just send them off an email and say, spots, I'm holding it for you until February 3rd, let me know, you know, we've given you, sort of first dibs, so to speak, but, not first dibs, but, you know, but I just want to give them a heads up because, hey. But seeing both of you here, I thought, oh, this is perfect because I just. No. So mental health first aid, I typically do 3 times a year.
These sessions that we have.
Oh, these here?
Yeah.
They're about that. Yeah, we've had one other one already.
Yeah, the last one I missed was just the timing wasn't,
So
once
it's
you,
busy.
once you've kind of gotten on the mailing and well, I get notified the next month, is that kind of what happens?
For these, for the ROH?
Yeah, I think it's, but I also see it.
I don't know how,
online.
I don't know how they're advertised.
Sometimes I miss some being print on.
Yeah, that's
I'd like to get some of these in.
I
So I won't get there till maybe 5:15. I don't know what time Abby's supposed to be here. Okay, I'm gonna try and get there for 5 then. No, I'm not worried about waiting around, no, no, so, but, I just, okay, no problem then, fine. Okay, but Oliver's, like, we're good, right? They can clear this up.